A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These guidelines are to improve and maintain the standards of the CPD program conducted by SRI. And thank you for the strict adherence for the CPD regulations and for your kind compliance. So today's topic is pain management in rheumatology. The guest speaker for today is Dr. Dilrukshi Thennakone, Consultant Rheumatologist, District General Hospital, Gampaha. Over to you, madam.
Good morning, ladies and gentlemen. Today, for our presentation, the topic would be pain management in rheumatology. During the course of this presentation, we would be trying to find out the answer to a few questions. So we start off with what pain is. Pain, by definition, is an unpleasant sensory and emotional experience which is multifaceted, which is associated with or resembling that associated with actual or potential tissue damage. It encompasses a multiple interacting biological, psychological, and social factors. Factors like obesity, sleep quality, mood, illness beliefs, avoidance behavior, rest and activity also influence pain. Now, if we go back to our undergraduate days, we know in this diagram, we will know how we perceive pain. So we have the receptors, and from there, the afferent fibers would be conducting this, the sensory stimuli first to the spinal cord, the dorsal horn, and from there to the higher centers of the brain, where it is analyzed, and the response is transferred back via the efferent pathways to the either to muscles or to the effector organs, muscles, or to other organs, especially skeletal or smooth muscles. So we know this is how pain is perceived. Now we will look at some of the types of pain. We have pain, which is called nociceptive pain. Here it's a response of sensory nervous system towards actual or potentially harmful stimuli. Nociceptors are sensory endings on nerves that can be excited or sensitized. For example, nociceptive pain could be an ankle sprain or a torn tendon in one of our patients. And we have nociceptive inflammatory pain, which is mediated by inflammatory mediator chemicals. The inflammation leads to three responses, namely hyperalgesia, allodynia, and sympathetic maintained pain. We see inflammation in our patients a lot, and nociceptive inflammatory pain is seen in most of our patients. Then we come to neuropathic pain, which is due to a nerve injury or disease of nerve tissue. It is described as burning, shooting, stabbing, or electric shock-like pain, and can be seen in herpes zoster, sciatica, cervical lumbar radiculopathy, and also in diabetic neuropathy. It is often associated with allodynia, which is a central pain sensitization leading to triggering of pain response that usually does not provoke pain. For example, light touch or gentle movement will provoke pain in this instance. Thirdly, we come across nociplastic pain, which is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing activation of peripheral nociceptors or evidence for disease or lesion of the somatosensory system causing the pain. The reflect changes in the way nervous and immune systems function, And conditions like fibromyalgia, chronic pelvic pain, chronic low back pain are examples for this type of pain. Now we know pain transmission is through action potentials that are generated in the afferent nerves and conducted to the efferent nerves. So we have the afferent nerve endings and the efferent nerve endings, the presynaptic and the postsynaptic clefts, or the synaptic cleft, where this transmission is chemically mediated. There are a lot of voltage-gated channels that are involved in the electric transmission or the action potential. Voltage-gated sodium channels are involved, and in the chemical mediation, we have voltage-gated calcium channels, calcium influx into the cell, which brings about release of chemical mediators that are stored in vesicles in the presynaptic endings into the synaptic cleft, where these are taken up by the postsynaptic membrane. So this means that there are many neurotransmitters that are mediating pain. For example, catecholamines, calcitonin G-related peptide, bradykinins, cytokines, prostaglandins, leukotrienes. Then we have nerve growth factors, gamma-aminobutyric acids, cannabinoids, norepinephrine, all acting as neurotransmitters. Then we come to the next question. Why is it important? Why pain is important to us? Why are we studying about pain? Pain is the predominant symptom in our patients, especially with inflammatory arthritis and osteoarthritis. But generally, it would be the most common presenting symptom in most of our patients and in patients in general. And we also would have experienced it at any time, sometime during our life. It contributes to many hours of loss of work, affecting the economy, affects the income earning capacity of the breadwinners of the family, which in turn affects the well-being of the family. Then the main it's a main component on the health budget of a country, of the society. And also it affects the society because a person with pain will have less social interactions. It will affect the family and the society at large. So that is why we should learn about pain and how to manage pain. In managing pain, so our objectives because of that would be to reduce the pain in our patients, increase physical functioning, the activity of the patients, and also the psychological functioning, which is mainly the emotional well-being and participation in social activities. This in turn will reduce the cost on the families, on the individual, and on the society. Now, when we start off with the objective of managing pain, first we must screen our patients for the pain. So for these, different tools and scales have been used. Some of the pain rating scales are Baker scale, numerical scale, flux scale, and pain ad. So these are used not only, now these are general tools that are used in patients with pain, not only in patients with rheumatological pain. So now we come to the Baker Faces pain rating scale, where if there's no pain, there's no hurt, and a smiley face is seen. If it hurts the worst, a scale of 10, a score of 10 is given, and a crying face is shown. So we can show these scales to the patient and ask them to rate where they are. And depending on this, we can screen and see whether it's a mild or a moderate or severe pain that the patient is experiencing. And these kind of visual analog scales are used extensively in our patients as well. Then we have numeric rating scales, again, where the patient is asked to number the pain on a scale of 0 to 10, where 0 is no pain at all and 10 would be the worst pain. And accordingly, 1 to 3 would be mild, 4 to 6 moderate, 7 to 10 would be taken as severe pain. Then the FNACC pain scale looks at the face, the legs, activity, cry, and consolability, and a score is given. Now, all these categories are can be given 0, 1, or 2 score, and you add all these and see what the total score is. If the total score is 0, the patient is relaxed and comfortable. 1 to 3 could be mild discomfort. 4 to 6 moderate. 7 to 10 would be severe discomfort. Now, pain AD scale is mainly used in patients with dementia. So not only in our patients, these patients, we can use these scales on other patients as well. Then we have to look. Now, we have been screening for pain. We know what pain is. We know why it is important to treat pain. So how do we set about treating pain in our patients? Now, we have to remember always the patient, the pain management. It has to be the assessments, treatment, everything has to be guided by a patient-centered framework. This cannot be overemphasized. It has to be catering to the needs of the patient and the family. And it has to be via a multidisciplinary plan. We have to be guided by scientific evidence, whatever is available to us, and also guided by pain characteristics. What has the patient had so far, the ongoing or the previous or the ongoing treatments? And we have to also look at psychological and other pain-related factors. So very quickly, the ABCDE of a pain management principle would be to ask about pain regularly, believe the patient's or family's reports on pain. Do not ignore if they complain of pain, screen and believe, screen for severity. Choose appropriate pain control options. We have to deliver the interventions in a timely, logical, and coordinated fashion. And we have to empower patients and their families, get them involved in the pain management plan. So when we talk about pain management, we know we can manage them non-pharmacologically as well as pharmacologically. So we would be first looking at non-pharmacological management of pain. So this is a rather this gives an elaborate account of the different modalities that can be used in pain management. For example, education, exercises, aerobic, muscle strengthening, then functional training, occupational therapy, mobilization, special activities, cognitive behavioral therapy, relaxation, diet, orthosis, assistive devices. Then we have physiotherapy. Also, remember smoking cessation, general well-being. These are also important in pain management. You will have to look into these aspects of your patient as well. If you look at, now we know a lot of our patients undergo these non-pharmacological pain management strategies. If we look at physical therapy interventions, we know that they can receive therapeutic exercises, passive range of motion activity, then active assistive range of motion exercises, active range of motion exercises where the patient themselves would be doing the exercises. Passive is where the therapist will be moving or doing the movements. Then we apply some resistance and ask the patient to do progressive resistive exercises, balance training, gait training, postural corrections, ergonomics. These are very important in managing pain in musculoskeletal conditions. Manual therapy, for example, mobilization. manipulation of joints, myofascial release, especially in muscle spasm conditions, massage. These are very important and relieves pain in our patients. Other modalities can also be used, and these have been proven to be beneficial. For example, electrical stimulation, TENS therapy, then ultrasound therapy, diathermy, infrared, hydrotherapy. We also use cold laser, hot packs, ice packs, paraffin wax therapy in treating our patients with the aim of pain reduction. Occupational therapy could assist in activities of daily living. Ultimately, that is what we want to achieve. We want the patients to be independent and get about their activities without pain or with the minimal restrictions. So adaptive devices to simplify tasks. We know in our patients with chronic deformities, those who find it difficult to grip, we might modify the handle of the comb or the handle of a spoon or the pen, so that they have more area to grip and the grip is easier and less painful. So these are the assistive methods that are used by the occupational therapists in relieving pain. Also, patients can be taught on energy conservation techniques, therapeutic exercises, and they can be prescribed splints to use to relieve the pain. Apart from mainly we use physical therapy, occupational therapy in our patients, but apart from that, patient education, advice on physical activity, exercise, orthotics, psychological social interventions, sleep hygiene, and also weight management is very important in our patients. When we talk about exercises, now we have strengthening or resistance training exercises versus aerobic exercises, land-based versus water-based, group exercises versus individual, home-based, supervised versus home-based, progressive versus non-progressive, and multimodal versus unimodal. So no head-to-head trials have been done to see which is more beneficial, but in general, strengthening land-based strengthening exercises which are supervised have shown to be beneficial. Then we know that some of the orthotics that are used in our patients can be helpful. It will have a positive effect on pain, for example, orthopedic shoes, splints for hand away, insoles, and orthotic gloves. Psychological interventions could be by way of cognitive behavioral therapy, mindfulness, stress management training, relaxation, and also biofeedback. Now, with these non-pharmacological management modalities in mind, EULA, which is European Leagues Against Rheumatism. It's a collection of rheumatological associations in Europe. One of the main rheumatological associations in the world have come up with recommendations for management of pain in patients with inflammatory and osteoarthritis, but in particular, they have looked at non-pharmacological management of pain. This is because under pharmacological management of pain, we have general pain management guidelines as well as management of the different rheumatological conditions. That is, for example, say if you manage in the management of rheumatoid arthritis, the use of disease-modifying anti-rheumatic drugs will also reduce the pain. Say, for example, in gout, the use of colchicine will also reduce pain. But that I will not be dealing with that in this lecture because it's beyond the scope and it's a lot. We will not be able to cover all that. So what we are going to look at is are these Ula recommendations, mainly the non-pharmacological. Now here what they have done is they have uh, uh, a task force has been formulated to look at literature reviews that have looked or analyzed use of non-pharmacological pain management modalities in our patients, and they have reviewed these reviews. Say, for example, more than 150 reviews they have reviewed, and they have seen positive effect and negative effect or no effect in these reviews, and they have numbered the given a number for these reviews, the number of reviews, the direction, whether it's no, zero, positive, or a negative. You will not see any negatives here. They have looked at these things and the quality of evidence for this. So in this, it's a systematic review of reviews, randomized trials, and they have looked at different modalities and how they will affect pain. So they have looked at education and self-management in patients with RA, spondyloarthritis, osteoarthritis in general, osteoarthritis of hand, hip, and OA in general. And they have shown that in RA patients, education and self-management, 8 reviews have looked at it and they have shown positive effects. 2 plus is there. In osteoarthritis, general osteoarthritis, they have shown positive effects. Osteoarthritis of hip or knee and knee alone also has shown positive effects of education and self-management. Orthotics, in the same way, the use of orthotic gloves in rheumatoid arthritis, splints, insoles, and orthopedic shoes have shown to be beneficial in some of the studies. In hand or wrist osteoarthritis, they have shown, a number of studies have shown splints to be beneficial. And in osteoarthritis, I think of the knee has looked at a lot of reviews are there looking at different modalities. And here they have shown braces to be effective in 10 of the reviews and insoles to be beneficial. There's one is questionable and positive effect, and this is the quality of evidence. Also, they have looked at psychological interventions, and we see here cognitive behavioral therapy has been studied in a fair amount of reviews, and they have found it to be positive. In osteoarthritis, general as the cognitive behavioral therapy as well as psychological and coping interventions have positive effect. Then weight management, especially in OA hip or knee and osteoarthritis of the knee, is where they have done the most number of reviews, have shown positive effect. Also, comprehensive physical therapy has been reviewed in one which has shown positive effect. Now, they have also looked at general exercise, aerobic exercise, strength and resistance exercise, and has shown the effects on mainly osteoarthritis of the knee in general exercise, osteoarthritis of hip or knee, hip, and also aerobic exercises in osteoarthritis of the knee had been shown to be beneficial. Strength and resistance exercises beneficial in a fair number, but mainly in osteoarthritis of the knee. They have also analyzed the studies which included acupuncture, massage, thermotherapy, ultrasound, electromagnetic therapy, laser therapy, manual therapy or mobilization, and other effects as well. Now, with these analysis, they have formulated certain recommendations, and these are the recommendations for the health professionals approach for pain management in inflammatory arthritis and osteoarthritis. There, the level of evidence is strongest with the 1A, and the strength of recommendation is higher with A. So we see here the first one is assessment by health professionals should include following aspects. Assessment is brief or extensive depending on factors such as available time, whether it is first or regular consultation, the need of the patient. So assessment is the level of evidence is 4. Then the fact that patients should receive a personalized management plan with the aim of reducing pain and pain-related distress. Again, the level of evidence is 4. This is because these have not been studied in these reviews, not that they are not important. So they have come up with the recommendations based on the reviews, and according to the reviews, we see that the patients receiving education is highly recommended. So we should educate our patients. What are they having? What are the things they should do and should not be doing to help in managing their pain? Next, we have, if indicated, the patient should receive physical activity and exercise. So they should be engaged in physical activities, engaged in activities of daily life, which will increase their social participation as well. Now we see that this is highly recommended. Next one, we have the patient should receive orthotics if indicated, and this again is highly recommended by this group. Number 6, we have, if indicated, the patient should receive psychological or social interventions. This again is highly recommended. Next, the patient should receive sleep interventions. Again, somewhat lower than the previously 1A ones, but again is recommended. If indicated, the patient should receive weight management. And the last one is, if indicated, the patient should receive pharmacological and joint-specific pain treatment according to the recent recommendations. So these, the task force recommendations can be used to guide managing pain in your patients. But remember all the time that these strategies have to be patient-centered. So different patients will have different conditions, different priorities. Always you have to prioritize and make the management plan according to the patient's needs. This cannot be overemphasized. Then we will look at pharmacological pain management. We have to, when we manage patients with medicine, we have to always assess to prevent unnecessary use of medication. And out of the drugs that we are using, avoid unnecessary opioid use, reduce that this in turn will reduce patient abuse of drugs. We have to assess pain at different levels or stages and either escalate if the patient is not responding, or step down if they are responding, for step down in order to increase the compliance, reduce side effects and dependence. So in pharmacological pain management, have adequate knowledge about the pain, assess the degree of pain through evaluation, prescribe the appropriate medications. We have to balance out the optimum dosage of drugs with their side effects and give what is really needed. And it is recommended, if you are using opioids, give opioid rotation so that the side effects are less, abuse and dependence is less. With this, we will have a quick look at the WHO Analgesic Ladder. Now, this Analgesic Ladder was put forward by the World Health Organization many years ago, in 1986, and it appeared in a handbook called Pain Management in Cancer Patients. So it was first put forward for management of pain in cancer patients, but since then it has been widely used as a guide for pain management, both in patients with cancer and also in non-cancer patients. So now this is the initial ladder that came about, and later on it was updated to include another step. So the first ladder consisted of 3 steps: step 1, step 2, and step 3, where mild, moderate, and severe pain was managed. And later on, they have added a fourth step and made the ladder bidirectional. So we'll have a look at this analgesic ladder in a bit more detail. So this analgesic ladder centers on 5 key principles. That is, the drugs are given by mouth. So oral route is preferred over IV or other routes, oral whenever possible. And by the clock, that means regular intervals. The drugs to be given at regular intervals or round the clock rather than on demand or as needed. Then it is suggested that it should be given by the letter, that is according to the pain severity, intensity. Fourth principle is that it should be individualized therapy, and then the fifth is proper medication adherence. So let us have a look at the first step, which is mild pain. For this, it's recommended that non-opioid analgesics like acetaminophen or non-steroidal anti-inflammatory drugs could be used, and you can use increasing doses, and a maximum dose could be used. These can be combined with adjuvants if needed. We'll have a look at what these adjuvants are later on. So step 2 is moderate pain management, where weak opioids like hydrocodone, codeine, or tramadol could be used, again with or without non-opioid analgesics like acetaminophen or non-steroidal anti-inflammatory drugs, with or without adjuvants again. So these can be combined. Step 3 is management of severe and persistent pain, where potent opioids like morphine, methadone, fentanyl, buprenorphine, and hydromorphine can be used. Again, these can be combined with analgesics, non-opioid analgesics like acetaminophen, non-steroidal anti-inflammatory drugs, and adjuvants. So let us have a look at these adjuvants. Adjuvants or co-analgesics refers to a vast set of drugs belonging to different classes. These can be used, they are given typically for indications other than pain management, but can be used in pain management as well. For example, antidepressants like tricyclic antidepressant, serotonin norepinephrine receptor inhibitors like duloxetine or venlafaxine, anticonvulsants like gabapentin, pregabalin. Then we can also use topical anesthetics like lignocaine, lidocaine for pain management. Corticosteroids, bisphosphonates, cannabinoids have also been shown to be used as adjuvants in pain management. Now, if you can remember here, we talked about modification or updating the analgesic ladder since it was first introduced. So the fourth step, which is the invasive and minimally invasive treatment. Let us have a look at this fourth step now. It consists of non-pharmacological procedures where interventional and minimally invasive procedures are included in this step. For example, epidural analgesia, intrathecal drug administration with or without a pump, using a pump, neurosurgical procedures like lumbar percutaneous adhesiolysis, neuromodulation strategies like brain or spinal cord stimulation, nerve blocks, ablative procedures, and also palliative radiotherapy. Now, remember when we talked about the ladder, if we go back to the ladder, you can see here it was mainly the initial introduction of this ladder was for the management of chronic pain in cancer patients. So we have a stepping up of the ladder where when the pain intensity increases, you go up, building on the uh, drugs that are more potent. With the updates and modifications, we can see upward trend as well as stepping down the ladder as well has been introduced. So if the patient is having more acute pain, then maybe it might be indicated to start off with very potent drugs. And as the pain response come down and wean off the medication as the patients recover from the acute pain. So this has been the modification that has been introduced to the WHO Analgesic Ladder, the updates that have been introduced. So when we talk about pain management, we have to see what the outcomes are. So the 4 A's of pain treatment outcomes would be analgesia. We have to make sure that the patient is free of pain. And we have to make sure that they are able to engage in their daily activities, be functioning normally, and have a high quality life. This, again, we have to keep in mind, we have to reduce the side effects or the adverse effects, and we have to monitor these in our outcomes. And also look at aberrant drug-related behaviors like addiction. And remember, even though we have been talking about pain management in rheumatological patients today, I have not been talking about management of specific rheumatological conditions. That is because different conditions will have to be managed differently, and we will not be going into detail of the management of each and every of these inflammatory arthritis. So remember, when we are dealing with patients with pain, our aim is to provide pain relief. So to that end, remember, pain is inevitable. All of us go through pain at some point, but suffering is optional. So I hope you have gained something in managing your patients with pain to relieve them of their suffering and to increase their quality of life. Thank you.
It was a very informative lecture. Thank you, madam. So, once again, our sincere thanks to Dr. Dilrukshi Thennakone, Consultant Rheumatologist, District General Hospital, Gampaha, for her excellent lecture and the precious time. However, due to time limitation, Dr. Dilrukshi won't be able to answer your questions. And if you have specific questions, you can email us on office313@gmail.com. And let's conclude today's session. Thank you for your participation. Kindly fill the link in the chat box and give your feedback and answer the post-assessment questions to receive your e-certificate. Thank you.